off.
All right, well, we'll go ahead and get started. So, first of all, hello and welcome. Thank you for joining us for the SAMHSA sponsored webinar, Healthy Starts Postpartum OUD Care Transitions for Mother and Infant. Before we get started, I'd like to cover a few housekeeping items. To start off, this webinar is being recorded. The recording will be available on SAMHSA's YouTube channel in approximately 2 weeks, so feel free to revisit or share it with colleagues. Closed captioning is available for today's session. To enable captions, click the arrow next to the CC button on your screen and select Show Titles. You'll see a few poll questions throughout today's webinar. We invite you to participate. They're a quick way for us to learn more about you, our audience, and enrich today's discussion. If you have questions during the presentation, please submit them using the Q&A feature located at the bottom of your screen. We'll do our best to address as many questions as possible during the Q&A portion. At the end of the session, we ask you to take a minute to complete a brief anonymous evaluation. Your feedback will help us improve future webinars. Finally, I want to share a quick disclaimer. Next slide, please. This webinar is hosted by Hendel Incorporated through funding from SAMHSA. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of SAMHSA or the U.S. Department of Health and Human Services. Next slide. It's now my pleasure to turn things over to our first speaker, Dr. Mary Rory, Social Science Analyst at SAMHSA. Dr. Rory, over to you.
All right. Good afternoon, everybody. Give me a thumbs up if you can hear me. All right. Thank you so much. On behalf of SAMHSA, it is a true privilege to welcome you all here today. Thank you for the work you do each day to support mothers, babies, families, and communities. And so sometimes people like to leave a little early. We don't want you. We want you to stay. We don't want you to miss out on anything. So I'm going to give you your applause right now. I want to begin with humility and deep gratitude to pregnant and parenting women living with opioid use disorder. Thank you for your courage, your persistence, and love for your children. Your journey is not easy, and your strength continues to inspire the work that bring us together today. To the many caregivers and partners joining us across all sectors and communities, thank you. You represent the many hands, hearts it takes to support families, and you show care is not just possible, it's powerful. And at the center of this work are our babies, our future. Every baby deserves the healthiest possible start. Every parent deserves to be supported with dignity and respect. And every family deserves the opportunity to heal, bond, and thrive. When we strengthen care during the postpartum period, we are shaping the long term health and well being of families, communities, and future generations. That is why today's conversation matters. This publication is the latest addition to SAMHSA's Evidence Based Practice Resource Center, or as we love to call it, SAMHSA EBPRC. The center's resource helps all, including researchers, providers, and communities, implement proven strategies across prevention, treatment, and recovery. If you haven't explored the Resource Center yet, I encourage you to take a look. It's full of tools and resources that can directly support your work. Today's webinar, Healthy Start Postpartum OUD Care Transitions for Mother and Infants, offers practical evidence based strategies to support care teams in delivering coordinated, compassionate care during this critical time. The postpartum period can bring physical recovery, emotional changes, sleep disruptions, and shifting access to care. And yet, It is also a time of profound opportunity, an opportunity to stabilize recovery, to strengthen family bonds, to align systems of care, and an opportunity to deliver the kind of coordinated, compassionate support that truly change lives. This work reflects shared priorities across SAMHSA and Health and Human Services to expand access to evidence based treatment, including medication for opiate use disorder, to strengthen maternal and behavioral health outcomes, and to ensure that cure is coordinated, person centered, and grounded in dignity. It also aligns broader national efforts to address substance use disorder, support recovery, and strengthen families, recognizing that these goals are deeply connected. And that the timing of this webinar adds even greater meaning as we celebrate global observances like International Day of Families, Maternal Health Awareness Month, Global Day of Parents, International Children's Day, and Post Traumatic Stress Disorder Awareness Day. These celebrations remind us that supporting families and advancing recovery are not isolated efforts, they are shared responsibilities both globally and nationally. So today is more than a webinar. It's a moment to learn, connect, and a moment to recommit. I encourage each of us to think about our roles, not just as participants, but as change agents. How can we apply what we learned today? How can we strengthen partnerships across systems? How can we ensure that mothers and babies continue to receive the care they need every day? Because real change does not happen in a single conversation. It happens when we carry that knowledge forward into our policies, practices, programs, and our communities. Recently, SAMHSA, in partnership with the Administration for Children and the Centers for Medicare and Medicaid Services, issued a Dear Colleague letter emphasizing the importance of expanding access to medications for opiate use disorders, or MOUD, for parents and family members. And now states can use Title IV-E prevention funding with a 50% federal match to provide MOUD to parents when children are at imminent risk of entering foster care, but who can remain safely in the home or in kinship placement with appropriate supports. We are incredibly fortunate to be joined by distinguished experts who bring not only deep expertise, but also a shared passion for improving care for pregnant and parenting women with opiate use disorder. This work reflects the very best of science, service, and compassion. And we are grateful for their leadership and their willingness to share their knowledge with all of us today. Let us use this time not to simply discuss what is possible, but to help make it real for every mother, every baby, and every family we serve. Thank you again for being here and for your commitment to this work. Dr. Lee, the floor, the virtual floor is yours. Thank you.
Thank you so much, Dr. Rory. Hello again, and thank you again for joining us today. My name is Lisa Lee, and I'm a science writer for Hendel, which serves as SAMHSA's expert contract for this publication. I served as task lead for this case study. As a person in long-term recovery from OUD, thanks to methadone, as a mother and as someone who has worked with this population for over a decade, I'm humbled to be part of this discussion. Next slide, please. You'll see our objectives for today's webinar on the screen. Next slide. This webinar and the accompanying publication were developed with the highest level of integrity, grounded in an evidence-based, scientifically rigorous process. The work reflects a thoughtful and methodical approach, drawing on established research, expert input, and a strong analytical framework. Every effort was made to ensure the content is credible, comprehensive, and aligned with best practices. The publication summarizes available evidence about the trends, challenges, and opportunities for women during the postpartum period. It highlights best practices, presents information about children and recovering mothers or CHARM, and offers guidance to providers and care teams. Next slide. Addressing opioid use in pregnant and parenting women prevents overdose deaths and enhances family and community resilience. Overdose is still a leading cause of death for people of reproductive age in the United States, and the number of pregnant women misusing opioids continues to increase. If left untreated, there may be risks for mothers and for babies. Next slide. A few challenges of OUD during pregnancy includes the risk of neonatal opioid withdrawal syndrome, which can also happen with the use of some MOUD. However, there are many strategies to help babies through withdrawal, including non-pharmacological approaches such as eat, sleep, and console. It is especially important for women to receive treatment, including MOUD, to reduce the risk of overdose death at a particularly vulnerable time, the postpartum period. Next slide. Before we go any further, we have a quick moment to hear from you, just to keep us all engaged on this important topic. There are no wrong answers here, just your experience, your insight, and your voice. You should see a poll pop up on your screen now. We'd really value your perspective, so please take a moment to respond to the question, which postpartum challenge do you believe poses the greatest risk for mothers with OUD? I'll just take a moment as you um, add your responses there. Again, thank you for participating. And it looks like, all right, we've got a pretty good mix there. Thank you, everyone, for participating. Your perspective helps to shape our next speaker's presentation. Next slide. Oh, you're on it. Many women with OUD report feeling a greater motivation for positive changes during pregnancy and the postpartum period. Perinatal treatment with MOUD reduces birth complications, improves adherence with prenatal care, offers overdose protection, and supports stability and well-being for moms and babies. Next slide. For this publication, our team conducted an environmental scan and literature review to identify practices and programs that work with women and families during the postpartum period. Program selection was based on this evidence, the adaptability and credibility of the program, and whether the program could describe its implementation process. Our team conducted outreach to a few programs that were identified and consulted with our partners. The CHARM program met these criteria and demonstrated how collaborative, team-based care can be implemented across clinical and community settings. We're truly excited about the speakers joining us today. They bring a wealth of experience, hard-earned wisdom, and practical real-world strategies and protocols that are making a difference for mothers and babies every day. We're especially honored that they've taken the time to be with us and to share their knowledge so openly. Their willingness to lift up and share best practices reflects the very best of this work. So I encourage everyone to lean in and engage. There's a lot to learn here, and I'm confident you'll walk away with insights you can carry forward into your own work. I'm honored to introduce our next speaker and subject matter expert, Dr. Martin. Dr. Martin, thanks for sharing your expertise with us today. I'll pass it over to you.
Lovely. Thank you so much, Lisa. Hi, everyone. I'm Caitlin Martin. I am an OBGYN and addiction medicine physician, and I live in Richmond, Virginia, and I work at Virginia Commonwealth University. At Virginia Commonwealth University, we have a program tailored to the needs of pregnant and parenting women with substance use disorders, where we co-locate the OBGYN care services, addiction treatment, including medications for addiction treatment, as well as wraparound services, including counseling, et cetera. So I have the pleasure of speaking with you today to give a few little snapshots from our publication and some clinical pearls. And no matter what you do, what role you play in your team, we're going to go over some things that and to inspire you to dive into this publication and learn more about what we all can do about what we're talking about today. So I'm not going to belabor the point as we get started, but we're all here because we know that substance use disorders are a very important, urgent public health crisis, and overdoses are continuing to be a leading cause of mortality in the United States. And like Lisa mentioned too, especially among reproductive aged people. Next slide. And it's not surprising then when we look epidemiologically at the trends of causes of mortality during pregnancy and through the year postpartum after pregnancy, that we're seeing that overdoses are continuing to play a major role in this public health crisis. And so this publication came out a few years ago, really highlighting the importance of mental health conditions, namely overdose related substance use, that is a leading cause of mortality, especially during the year after delivery, hence the topic of what we're focusing on today. Next slide. These data, when we're looking at the trends related to overdoses and substance use disorder related morbidity and mortality, and during the pregnant and postpartum periods, really is not surprising to me when I look at the data as a researcher, because addiction is a chronic medical condition, and just like diabetes and hypertension, it's not something that just comes up and goes away necessarily, like having the flu or the common cold. It's a chronic medical condition that does warrant interventions and care and non-stigmatizing care through a long period of time. And so when people get pregnant, diabetes and hypertension just don't go away, right? That's something that I manage as an OBGYN, and addiction is really no exception to that. And so when we're looking at the trends related to substance use disorders, and also when we're looking at the reproductive age life course, it's not surprising that these two things are intersecting and overlapping, and we're seeing substance use related morbidity and mortality being a strong driver of poor outcomes that we see for pregnant and parenting women with mental health conditions in this country. And so we're going to be using the ESPERT acronym or the experts framework today to go over some clinical pearls that I know everyone in this audience can take away and take back to their program. If you're a provider, a social worker, a peer recovery specialist, et cetera, et cetera, et cetera, we're going to go over some things related today that you can take some action for. And more importantly, too, we can destigmatize substance use disorders, including opioid use disorder, and the life-saving treatments that we can provide to women and families. So we're first going to go over screening. So the first letter is S in ESPERT. So screening. So screening is done not with toxicology or with drug testing. Next slide, but with validated verbal tools. And there's many of them, and I'm just going to show two on this slide and the next slide that have been shown in multiple research studies to be sensitive and specific. So they're really good at identifying people who are maybe at high risk of a substance use disorder, and on the flip side too. And so this is one example on the slide here of one validated verbal screening tool for substance use disorder that can be used during the pregnancy period. I like this one as an example because we have boxed here one of the questions, which is related to, have you ever believed that you needed to cut down on your substance use? And the other questions are asking about substance use before the onset of pregnancy. And so it's really important to start the conversation when you're talking to patients and clients about their substance use while pregnant, about what their substance use patterns were like pre-pregnancy, and then work your way forward, just given the heightened stigma and discrimination that surrounds substance use, especially during pregnancy. And I don't know about you, but if I'm going to be screening one of my patients for a risk of substance use disorder, I want to try to get the most accurate and comprehensive information possible so I can do the most possible too for that patient in front of me for taking care of them. Next slide. So this is another example of a validated verbal screening tool, is what we recommend for screening patients to see if they're at risk of a substance use disorder, that can be used in non-pregnant patients. So in the audience that we have today, I'm really going to emphasize the importance of universal screening using validated verbal screening tools for all women in the reproductive life course, especially. So pre-conception visits. As an OBGYN, we do well woman visits on a regular basis. And also when we're looking after pregnancy and through the postpartum and further years after that. Next slide. And so you probably seen the titles of these slides a couple times saying screening and the SBIRT approach is done with validated verbal screening tools, not drug tests. And I'm just going to emphasize this point some more. A toxicology test is not a screening tool. The point of a screening tool within the SBIRT framework, which is a framework that we recommend for all providers related to behavioral health, is to see if someone is at high, medium, or low risk for whatever the condition is that you're screening for. So I think about it kind of like the Edinburgh um, depression screening tool that we use in OBGYN clinics pretty commonly, right? It's a screening tool that I'm using to see if my patient is at high or low risk for postpartum depression, just as one example. And so those validated verbal screen tools on the last couple slides are a version of that for substance use disorders. Toxicology tests are going to tell you in this today is what substances are in my patient's system, or did they use cocaine in the last 3 days? Have they had recent substance use? Yes, it's going to give you information, but that is not the information that's going to tell you if a patient is at high or low risk for a chronic medical condition like a substance use disorder. I would never diagnose a patient with chronic hypertension, for example, based on one blood pressure, correct? I would want to look at their blood pressures over time, take a history, etc. And addiction is really, and substance use disorders are no exception to that. And so toxicology tests are sometimes used in clinical practice. I use them in my patients who are getting addiction treatment with me, for example, and I'm prescribing medications because it's an objective piece of information. It's kind of like my hemoglobin A1C, right? If I was treating diabetes, just to kind of give a clinical example. But I only am getting those tests in my patients where the test results are going to actually influence my clinical decision making. And a lot of times these test reports are not going to impact clinical decision making. And secondly, and most importantly, I'm only getting these toxicology tests in patients who have consented to me being able to obtain that toxicology test as part of their addiction treatment, to give an example. Next slide. So let's say that you did your screening with your validated verbal screening tool, not with your toxicology test, like we just emphasized, and you deem that maybe your patient is at moderate or high risk of having a substance use disorder. So again, that continued substance use despite adverse consequences, that chronic condition that we showed on our earlier slide with its formal definition. So in the SBIRT framework, you then go to the BI. So you go to brief interventions. Brief interventions are always going to incorporate tenets of motivational interviewing. Motivational interviewing is something that we all have the opportunity to practice and get better at. There's really no way of getting better at it than practicing it with your patients and clients. And it's also going to consist of assessments to look more deeply into the substance use to get towards a diagnosis, as well as common conditions that are comorbid with substance use and plans for frequent follow-ups. Next slide. So in assessing your patient more, again, if they screen positive on your validated verbal screening tool, these are the questions that me as an addiction provider, I am using to see if I'm going to render my patient a diagnosis now of a substance use disorder, a diagnosis of opioid use disorder, stimulant use disorder, etc. And so we use the DSM-5 where we take essentially a patient's history and we ask them lots of questions about their history of substance use, their current substance use, and then we kind of have to distill down their life story into these checky boxes. But that's just how the DSM-5 works. And so these are the examples of all the DSM-5 criteria that we use to diagnose someone with a substance use disorder. And based on how many of these that my patient meets of a checky box perspective, I then render them a diagnosis of mild, moderate, and severe. Just as a clinical correlation, most of my patients with opioid use disorder that I have the privilege of taking care of here in Richmond, Virginia, are meeting criteria for severe opioid use disorder based on these DSM-5 criteria. Next slide. But if you're someone who's not trying to give a diagnosis, you're not trying to give that ICD-10 code or whatever it is, but you're just trying to see, okay, is this person in front of me that I'm caring for in my capacity in the role that I play on my professional team? Do I really think they might have a substance use disorder? They have a chronic condition, and I need to proceed with linking them to treatment, right, to improve their outcomes. These are kind of my 3 questions that I tend to ask these days. My first question will be, how has substance use impacted your life? And sometimes I'll give prompts to my patients, maybe your health, your family, relationships, employment, and school. I always ask about prior overdoses. I think of it as kind of like a little proxy of seeing how severe someone's opioid use disorder might be, given the fentanyl infiltration that we've had, as well as many adulterants in the drug supply. And then I'm always asking my patients, at least for me, because I am an addiction treatment provider, what are your goals for treatment and recovery? So we can work together to try to meet those goals together through evidence-based treatments. Next slide. And so, like I mentioned, the brief intervention aspect is going to be that motivational interviewing, further assessments about your substance use disorder, and also conditions that are highly comorbid with substance use disorder. So there's two examples of some quick screening tools that you can implement into your practice and where you're working, or advocate for providers that you're working with to implement into their practice, looking for to see if your patient's also at higher risk of depression, PTSD, anxiety disorders, etc. Next slide. And so, or bipolar disorder. So, again, all these mental health conditions that I see clinically are highly comorbid. And also, it's important to know about these conditions because they can also complicate or make, I wouldn't say complicate, but make it more complex sometimes in the tailoring of pharmacologic and non pharmacologic treatment components to my individual patient's needs, because substance use disorder and these mental health conditions tend to have a bi-directional relationship and how they impact each other during the recovery trajectory. Next slide. Okay, so again, I know I'm going fast, but I'm trying to give these highlights too. So let's say that you have your patient, you did your screening, right? They screened, let's say that they screened high risk for a substance use disorder, again, for that chronic condition, continued substance use despite adverse consequences, right? The definition. Okay, you went to your brief intervention, you did some lovely non-judgmental, compassionate, motivational interviewing. You assess the patient for a substance use disorder diagnosis. You found that they meet DSM-5 criteria. You also are looking to see what other mental health conditions they might be at higher risk of through validated screening tools. Now we're going to proceed to the treatment aspect, right? And the first thing I would say is you want to talk to your patient or client and ask them and tell them what you're thinking. Like, tell them what I just said. Like, hey, I think you might have a substance use disorder if they're not already coming to you knowing that about themselves. And tell them, there's some treatments that I can talk to you more about that I think can help you reach your recovery and goals. Is it okay if we proceed in talking with that? So using that trauma-informed approach to ask for permission before proceeding to talk to the patient about treatment, because they just might not be ready for that. Next slide. So when we're talking about the treatments for substance use disorders that are evidence-based, there are many evidence-based treatments for substance use disorders. There are many behavioral health therapies, there's peer-led interventions, et cetera, et cetera. For the purposes of what I've been asked to talk about today, I'm going to focus on the FDA-approved medications. And in the multidisciplinary team that I work on, this is a big role that I play, is talking to patients about medication treatments versus my social worker, who literally works in the same room as me, is talking to them about all the other behavioral health and non-pharmacologic treatments that are evidence-based to help meet the needs of the patient that's in front of me. So for opioid use disorder, we have 3 FDA-approved medications for opioid use disorder for all people, including during pregnancy and postpartum: buprenorphine, methadone, and naltrexone. Just before, we're going to go a little bit more into that, but before we do that, just know that we also have FDA approved medications for alcohol use disorder, and there is a little bit of an overlap, but these are the 2 substance use disorders for which we do have FDA approved medications in the United States, which is great because I love being able to give my patients choices with regards to what they want for their treatment and recovery goals. Next slide. So just briefly, I'm not going to go into all the pharmacology, but both buprenorphine and methadone, which is going to be the focus of the medications for opioid use disorder, or MOUD, which is an acronym we commonly use, are both agonists at the mu opioid receptors. Receptors are like flags in your nervous system, in your brain, and throughout your body, where chemicals can bind to and activate and cause downstream effects. And so the opioid receptors are where things like heroin and fentanyl do apply to attach to and cause the effects that we already know about, correct? But buprenorphine and methadone are medications that have been formulated with long half-lives, etc., So when patients are taking the proper dose and taking it as prescribed, which is usually about once daily dosing, we'll talk a little bit more about that, then patients are going to be able to have stabilization of the areas of their brain that have, the wires and the chemicals have gotten dysfunctional from periods of active use, the ups and the downs, the withdrawal and the opioid exposure over time, to reach stability and create a foundation for treatments going forward. We're not going to be talking as much about naltrexone today, just given limited evidence in pregnancy, but I'm happy to answer questions about it. So I like this slide because it kind of gives like a visual snapshot of what I just said. So if you look on the left-hand side, you see that squiggly line up and down, up and down. This is when patients are coming to me in active addiction, active use of their substances, using opioids as the example right here. Right? They're continuing to use the opioid despite adverse consequences, again, that definition of opioid use disorder, in order to avoid withdrawal symptoms, in order to avoid sickness, right? And in order for my patient to feel, quote, normal. So patients are continuing to use the heroin, fentanyl, et cetera, to kind of be in that white bar in the middle to feel normal because their brain over time from periods of active use, the ups and the downs, and the neurotoxic effects of the substance use on the brain have gotten to the point where now the brain expects really high levels of neurotransmitters, which are chemicals in the brain like dopamine, that can only really be rendered by the substance that they're using, not by the normal everyday things that can cause higher levels of those neurotransmitters like dopamine. So patients, again, once they've reached the level of having an opioid use disorder, they are not using that opioid to, quote, get high or be in that green bar and that euphoric bar in this visualization. They're continuing to use the opioid to avoid withdrawal symptoms and to avoid the sickness and to feel normal because their brain physiologically has gotten to that point that it requires the opioid in order to get there. But when patients are on a medication for opioid use disorder like buprenorphine or methadone on the right-hand side of this visualization, and they're at the right dose and they're taking it as prescribed, you can see my patients can reach that level of stability and stay in that white bar in the middle, stay feeling normal. Like I'd like to tell my patients, I know you're at the right dose of your buprenorphine or methadone when you're feeling normal 24 hours a day. You're not feeling the lows and you're not feeling the highs. And this is how these medications work. Next slide. And so I like to include kind of, especially to the providers in the audience, but anyone else who's working with people who are maybe asking questions. Big misperception we get is these methadone and buprenorphine medications are, quote, replacing one drug for another. But I think I've explained to you that they're not. It's not the same as that squiggly line, the ups and the downs from the fentanyl and the heroin. It's achieving stabilization in the brain circuits for my patient to have a strong foundation to reach their treatment and recovery goals. And it's been very proven in research on a population level in the United States that when we do provide these medications as part of a treatment plan for opioid use disorder, the risk of overdose related mortality is reduced by over 50%, which is a better benefit than any other medication I've ever prescribed or ever will prescribe. Next slide. But in the postpartum period, while we're all here today, there are so many barriers that get in the way of patients, even if they get on these medications that are life-saving, to continue them through the year postpartum. And you've seen some snapshots related to those different factors as kind of perfect storm that happens in the postpartum period. Next slide. And so even we know from data that even if patients are getting medications for opioid use disorder during pregnancy, we're seeing about half of these patients discontinue these medications in the year postpartum when those overdoses are happening, like I showed at the very beginning of the presentation. So we have a long way to go at trying to help our patients and families continue these medications for opioid use disorder within the year postpartum if they're receiving them as part of their treatment plan to help them achieve better outcomes for themselves and their family. Next slide. And what can happen too in the postpartum period on or off medications is that it's very common for had substance use recurrence. Remember, substance use disorder is a chronic condition, right? You're going to have ups and downs. It really shouldn't be a surprise. And so when patients are presenting to me with substance use recurrence in the postpartum period or having trouble staying on their medications, that's something I expect, and that's something I want my patients to talk to me about, and that's something we want to address together to see how we can improve their outcomes through the year postpartum going forward. Next slide. And the one barrier I'm going to end on that was on the slide earlier is one challenge to patients staying on their medications and also reducing the risk of substance use recurrence and optimizing their treatment and recovery outcomes through the year postpartum. The one of the barriers I just want to highlight is stigma and discrimination. It is literally the biggest thing that keeps my patients from coming back to me, staying on their medicines. I just feel like my patients come in, they talk to me, we have this therapeutic alliance, but I feel like as soon as they leave my exam room, they're on a battlefield. Next slide. So no matter who you are, what can you do to attack this number one barrier to patients getting the optimal outcomes through the year postpartum? And it's really pushing person first language. This is a handout that's available online for free that really just gives you some examples of how we can all tweak our language at work and also around the Thanksgiving table, right, with our families and friends about using words like a person with a substance use disorder, an infant that was exposed to opioids in utero, instead of saying false things like an addicted baby or an addict, if that's not a word that you use to describe yourself having lived experience. Next slide. And so I'm just going to end here with some quotes from my patients, just talking about the stigma and discrimination regarding these life-saving medications. And I just want to empower all of us to take this home, and then we can all do something to improve the care for these patients through the postpartum period and also our language too. I'll end here and hand it over to Megan Masterson. Thank you.
Thank you so much, Dr. Martin. It was so lovely to hear all of that information, and I hope that I can continue this path forward and give folks with us today some tips about implementing the CHARM program or our lessons learned from CHARM. So, hi everyone, my name is Megan Masterson. I'm the Executive Director at KidSafe Collaborative. KidSafe Collaborative is a member of the Children and Recovering Mothers team. We serve as the administrator, providing logistics and admin support for the group. I live and work in Burlington, Vermont. CHARM serves Burlington and the surrounding county, as well as some statewide consultative support. On the next slide, we do have another poll for you all to answer, just to get a sense from each other of what coordinated services look like in your area, how well it's going. So in a moment, the poll will pop up and we'll give everyone an opportunity to answer. Hope everyone's had a second to answer, and we will see in just a moment what the results show. As with the first poll, there's no right answer to this. It's just what your experience is. Okay, so it looks like the majority of people have somewhat coordinated care. I think that in my experience, this is what I hear from a lot of folks is that it's going somewhat well, but there is a range across all levels of coordination. Next slide, please. My hope is that the Children and Recovering Mothers or CHARM team model will give all of you an opportunity to learn something new, whether you have highly coordinated care in your systems or it's something that you're still working toward. I think that there are pieces of this model that can work for everyone. What's really important to understand about CHARM is that CHARM is not a place, it is not a clinic, it is not a program. Instead, CHARM is a multidisciplinary group. It is made up of agencies that serve pregnant patients with a history of opioid use and their infant. What CHARM does is to provide coordinated care for these clients, as well as providing consultation and expertise and support to other professionals across the state of Vermont. We serve about 175 patients and their infants annually. Next slide. The goal of CHARM, like you've heard other speakers say before, is to improve the health and safety outcomes for babies born to patients with a history of opioid use. The way that we work toward this goal is to engage patients in prenatal care as early in pregnancy as possible, to engage them in MOUD care as early as possible, engaging our patients in additional treatment, and then looking at what social supports and basic needs the family needs in order to thrive together. Next slide. You will often hear us at CHARM say, everyone wants a healthy baby. This statement is really sort of our North Star. It is the thing that we come back to when there are differences or disagreements in what the next step is, what treatment should be taken, what recommendations should be made. Additionally, all of our CHARM team members recognize that we play a different part in helping clients achieve this goal. So, although we share the same goal and we share this philosophy, we respect each other in the systems and the work that we represent. And because we're made up of a variety of different organizations, there are sometimes differences in what is best, what should be done next. So we always are sort of coming back to this goal, this North Star, the thing that both CHARM members as well as our patients can share, which is everyone wants a healthy baby. These are our current CHARM team partners. So you can see that we have some different organizations within our local health system, UVM Health, both the Children's Hospital as well as other parts of the health system. We have some state agencies that are part of our CHARM team, including our Department for Children and Families, Department of Health, which is WIC, and then there are a number of nonprofit and community-based organizations that serve different roles in the community. What's unique about CHARM is that we are a partnership, a group of organizations from different places. Oftentimes, multidisciplinary teams are all folks that work at the same organization or work at the same place, but hold different roles. CHARM is different in that we're bringing together these distinct agencies and organizations. Next slide. When you think about bringing together partners like this, especially across agencies, one of the questions that we get asked the most often is, how do you do this? How do you collaborate? Particularly when you think about sharing the type of information that needs to be shared to best serve our clients. Sharing substance use treatment information, sharing medical information, sharing child welfare information. These are really confidential and highly protected sets of information. And so how can that be done? The main way that CHARM shares information is through a memorandum of agreement with the CHARM partner organizations. Part of that memorandum of agreement is a client consent to release form that all of our clients sign before we share and add them to our case list. In addition to our MOA, CHARM is also an impaneled child protection team. Empanelment is a Vermont state law that allows for the sharing of information in a very narrow and very specific set of circumstances. So although we are an impaneled child protection team, the vast majority of our information sharing is done through the client consent and the memorandum of agreement. Over the years, we have also looked at creating other ways to share information, for example, a shared database. What we have come to learn is that for us, we don't do any electronic sharing of information. We still take hard copy notes and share a hard copy case list at each meeting. This helps simplify some of the concerns related to sharing and storing of information. So this is what works for us. Charm meets once a month for a 2-hour meeting, and we utilize a collaborative staffing model for our patients. So once a month, we review a current list of cases and we prioritize patients in the order that you can see on your screen. So all new pregnant patients, all other prenatal patients, new babies 0 to 4 weeks, then 5 to 12 weeks, high-risk postpartum patients, and then other postpartum patients and families as time allows. We're reviewing anywhere between 20 to 25 cases in a 2-hour meeting. And so by prioritizing patients in this order, it allows us to be sure that we're discussing the patients and clients that are at highest risk or the most vulnerable, ensuring that we are taking care of them and thinking about them each month. Next slide. Because we meet monthly, it gives our team the opportunity to follow clients during their pregnancy until about 1 year postpartum. This means that our case review does not have to be incredibly in-depth. Unlike other case review or consultation models where you might have one chance to talk about your client or their family, Charm meets and talks every single month. So we are looking not at the historical information. We're not trying to cover every aspect of this family's life. Instead, we're thinking about how are they doing right now and what do they need next. This means we're looking at their attendance at prenatal or other medical appointments, participation in their treatment, what types of family or natural support exist. We're often discussing co-occurring issues such as domestic violence, mental health, looking at social service and basic needs, housing, transportation, food security, and beyond. This is really important because it allows us to think about each client and their baby individually and create next step plans for each of them each month. The other part about collaborative staffing that is really important is that not only does it serve our clients, but it also helps serve Charm and our team members. This model improves relationships between team members that often go on to exist and collaborate outside of Charm about different shared patients. It improves the overall system of care, not just the care for the specific clients on our list. Next slide. Charm has existed since the early 2000s, and so we have learned many lessons over the last 20 years or so. Some of the early barriers to Charm included what information to share, how much information would be shared during these collaborative staffing meetings, who attends the monthly meeting, what is the balance between having enough people at the table to do true collaboration, but not having too many where it's ineffective and overwhelming. Charm didn't have a model to base itself on, so there were no guiding documents for an interagency process. We didn't really have any sense of how to do this at the beginning. Because our Department for Children and Families, Family Services Division, is a member of the Charm team, there were lots of conversation about reporting suspected child abuse and neglect, what the role of child welfare was on the Charm team. And then, of course, always thinking about stigma and misconceptions related to opioid use disorder, what it means to be a parent with a history of opioid use or OUD, and what it means for infant safety. Although that was an early barrier, I will also say that that is ongoing work. It is something that as a team, we are always thinking about, learning from, and moving forward. Next slide. What I get asked very often is, how do I do this? People learn about Charm. They often say, this sounds really cool. I wish there was something like this where I live or where I work. And so what do I need to do? And so here's what I tell everyone. The first and most important thing that you can do is find your champions. These are people in different systems who will believe in this model, believe in the power of collaboration, believe in the importance that it makes for your clients. They are the people who are going to stick with you as you work to implement this model. This is not an easy thing to do. There will be barriers as you do this. If you have people who are your champions, it makes the process easier and it allows you to keep coming back to the table no matter how hard it gets. After you find your champions, you then can think about who needs to be at the table. You may not have a champion in every system or from every organization, and that's okay. But you probably will want these people represented on your team. Who are the critical partners and invite them? You can think about who is serving this population of patients very often, who are you making referrals to, etc. We recommend engaging a neutral convener to facilitate the process, navigate what we call turf issues, and keep things moving forward. KidSafe Collaborative serves as the neutral convener for CHARM. And what we have learned over the years is that having someone do this is important because there will always be disagreements, there will be friction. Sometimes the approach between one team member and another, you don't see eye to eye. When you have a facilitator that represents a specific system, a specific organization, that can be a challenge in navigating these perf issues. And then we tell people to find your common ground. As I said, CHARM's common ground is everyone wants a healthy baby. You are going to need a North Star. You are going to need a shared philosophy and a shared goal. If you can establish that, it will help make all of the next steps possible. After you've done these first steps, then you can begin to share expertise and build information and share information. This helps you build trust. Ultimately, the success of CHARM is based on both the incredible clients that we serve and their tenacity and their caregiving, but it's also built on the trust between team members. As I said before, we're sharing really sensitive and confidential information. You have to know that the person sitting across from you is holding that information in the same way that you are and working toward a shared goal for your shared client. Begin to develop your operating agreements. These are your releases, your memorandum of agreements, and then develop your team meeting. It may look different where you live, and that's okay, but you need to have some sort of team meeting that works best for you. Next slide. CHARM is a specific model with a specific set of components, but it can be adaptable. What CHARM looks like now in 2026 is not what CHARM looked like in 2005 or 2010. There are threads of these core components that we recommend for anyone interested in this work. But it can be adaptable and you have to start somewhere. So, as I said before, identify your core team members. Your core team is a core component of your model. You need to have the same people around the table every time you are discussing your clients because it builds that trust that is critical. Determine your shared philosophy and goals. Develop information sharing. Establish your administrative process. Who's going to send out the meeting link? When are you going to meet? Who's going to take notes? And then work on building your trust and collaboration. Often you will have many meetings before you are actually doing any client reviews. There are these adaptable elements as well. What your case review focuses on and the style of your case review can be adapted. Your inclusion criteria, CHARM serves patients with a history of opioid use or opioid use disorder. That may look different in your area. The length of care coordination, we follow patients through about 1 year postpartum. That may be different for you. And who your key team members are will depend on the agencies and organizations in your area. As I said, you have to start somewhere. It doesn't have to be perfect. You just need to take the next step toward this collaborative model.
Well, thank you so much, Megan and Dr. Martin. And thank you, attendees, for submitting your questions. I am going to do my best. I hope I didn't miss any that came in. but I'd like to start with the one I think, Dr. Martin, this came in during your presentation on MOUD, and I think there was some um, s- it was unclear around naltrexone being approved for utilization during pregnancy. I thought this question would come in. So people ask, can I ask when naltrexone was approved for utilization during pregnancy? So if you'd
Yes.
like to offer further explanation on that.
Yes, of course, of course, of course. Yes. Thank you so much for asking about that and seeing that there are three FDA approved medications for opioid use disorder, the buprenorphine, methadone, and naltrexone. Um, just a little bit of a terminology. Medications are typically not approved in pregnancy by the FDA unless it's like a pregnancy specific condition, if that makes sense. Medications can be approved for, hypertension, opioid use disorder, et cetera. And then over time, clinical guidance can recommend, like, oh, these medications appear to be safe and effective in pregnancy. And then we recommend them, ACOG, et cetera, SAMHSA, et cetera. So just to kind of put terminology out there. And so naltrexone is a great example because right now it's kind of in that middle of the spectrum, what I just mentioned. Naltrexone is FDA approved for opioid and alcohol use disorder. Naltrexone is available in a pill form and also in a long-acting injectable form. The brand name is called Vivitrol in that situation. And naltrexone is not included in the original SAMHSA clinical guidance for the treatment of opioid use disorder, which was published quite some years ago now, because it just wasn't a lot of data on it at that time in pregnancy and postpartum. Since then, there have been multiple what we call observational studies. So we don't have like a randomized controlled trial, which is in a fancy way of saying like our best version of research for naltrexone in pregnancy. We do have that for buprenorphine and methadone, which is lovely. From that was published quite some years ago. But we do have all these studies that have looked at people over time who have taken naltrexone in pregnancy. And so far, what we're seeing, again, without that level one evidence or without the randomized control trial, but kind of taking what we can get, it does appear that there's no consistent data or no consistent evidence of proven fetal harm or showing that this medication causes birth defects or causes worse outcomes for the infant in particular. We're looking at the infant outcomes compared to buprenorphine and methadone. That's what we're seeing so far, but we still have a lot of unknowns about the neonatal effects. I would say from a maternal standpoint, we have even less is known about using high level observational data or are of course no trials. So we're not really sure exactly what the outcomes are looking like specifically in the pregnant and postpartum period for naltrexone compared to buprenorphine or methadone. Generally, how I practice, again, in this kind of data-free zone, is that if I have a patient who is stabilized on naltrexone during pregnancy and they become pregnant, I will say, do not stop your naltrexone. Come talk to me. And let's talk about the risks and benefits, the pros and cons, or have that risk discussion that we have for pretty much every medicine in pregnancy. And anyway, like anyone who's on a medicine and they become pregnant, your provider is going to have a risk discussion with you, right? What is the risk of the medicine versus the risk of not taking the medicine for your health and your baby's health, given that you're pregnant? And a lot of times my patients will continue their medication because we have that. And then sometimes patients say, hey, you know what? I was planning on kind of tapering off this anyways, and then they do it. And then I have actually have a subset of patients where the naltrexone was not really working very well as their pregnancy progressed, and they actually switched to buprenorphine, which can have more of a potent effect, especially for cravings in addition to the overdose protection. And so I've kind of seen everything of the gamut when we're talking about naltrexone in this data-free zone. And my job is to give them the information and then let the patient make the best decision that's best for them and their baby.
Thank you. There are several more questions about MOUD. So I don't know if we want to address them quickly and move on to
Yes.
charm, or if you'd like me to ask Megan a question.
No, I can go. I see them in the chat. The next question is about Sublocade, or Sublocade is a brand name for a long-acting injectable for version of buprenorphine. There are two brand name versions of long-acting injectables on the market, Sublocade and Brixadi. There I can give Lisa a paper that is a good review of Sublocade, because again, we're kind of in this data-free zone. We do not have our randomized controlled trial of Sublocade use in pregnancy. But so far, what we're finding is that if patients, again, very similar conversation I said earlier, are gaining benefit on the Sublocade, we have that risk discussion with them with updated evidence that has come out showing that if a patient is really saying that the Sublocade is what works for them, for their recovery and treatment goals, and we continue it through the pregnancy and especially in the postpartum period, especially then. But if a patient says that after that discussion that they want to switch to the sublingual version of buprenorphine, which is the brand name Suboxone, and then we'll do that too. So it's really having that risk discussion. But pretty much, that person that asked that question probably just wanted to know if it's okay to give Sublocade in pregnancy. And generally, we are giving after a risk discussion, we are giving it to them. There's a question that just came up about FDA approval. Again, there is no such thing as being FDA approved in pregnancy. Things are FDA approved for the treatment of their condition, and then we have evidence to inform clinical guidance. There is a recent randomized control trial, actually, that was published called the MOMS trial that looked at the weekly version of the brand name of an long-acting injectable form that actually did find very good outcomes for moms and babies with opioid use disorder. And that's the only randomized control trial we've had for medications for OUD in a long time. And so we're all very encouraged by that. So the MOMS trial was recently published, which again showed good outcomes. And so again, it's great that we're having more and more options for patients who want to be on buprenorphine containing products, both the sublingual and the long-acting injectable. For alcohol use disorder, there are two medications. There are three medications that are FDA approved for alcohol use disorder: naltrexone, which I already talked about, acamprosate, and disulfiram. And so all three of those medications are approved for alcohol use disorder. We tend not to use disulfiram in pregnancy because of the risk of teratogenicity that has been shown in preclinical studies. And so we talk to patients about a risk discussion regarding naltrexone and acamprosate when we're talking about medications for alcohol use disorder. The next question is about kratom. Thank you for asking. That's such a hot topic these days. Again, I'm saying so many things without like really robust data, and I'm a researcher and I hate doing that, but I know people want answers to questions. So I'm just giving that caveat again. Kratom. Kratom is something that you can get from the gas station. It has the properties of kratom, very briefly, can have opioid agonist effects similar to what we're seeing with other opioids, like heroin, etc. So very short. And so if a patient is coming in with kratom use and they're desiring medication treatment to help them cut down and eliminate the kratom use, there are case series that are looking at buprenorphine. Sometimes the doses of buprenorphine that we're using, the sublingual version, are lower. Clinically, again, no data to say why or anything yet, compared to patients who have been using fentanyl. But clinically, I am offering my patients buprenorphine for kratom use. The last question I see is about breastfeeding. We highly recommend breastfeeding for all of these moms and babies, all the dyads. Breastfeeding is pretty much the thing above anything else that can help reduce the risk of severity and badness related to neonatal opioid withdrawal syndrome, or NAS, or withdrawal of the neonate after birth. So we highly recommend breastfeeding for all of these prescribed medications that I'm speaking about. And that's a very short answer to a lot of nuance, but there are recent 2023 ABM, or the American Breastfeeding Society, they did publish updated guidance, and they actually about substance use disorder and breastfeeding. It's a very excellent document, and they include copious data and evidence about that inform the recommendations, not just about substance use itself, but about substance use disorder medications like buprenorphine, methadone, acamprosate, etc. So highly recommend that reference too for more detail. I think I got all your questions. You're muted, Lisa.
Oh gosh, thank you. Multitasking. Thank you so much, Dr. Martin. I'm going to move on to a few of the charm questions. So one of them that came in was, is there an organization like Charm in the state of Georgia?
That is a great question. To my knowledge, I am not aware of a charm team or a charm like team in the state of Georgia. And I will say that that doesn't mean that there is not one. It just means that I'm not sure if there is. There are charm like teams in other states. North Carolina has one, Wisconsin is working on one, Maricopa County in Arizona. So the other part of this is that many entities, jurisdictions, organizations have collaborative teams that are meeting. Oftentimes, they're housed within one organization. So, for example, a large medical center might have a collaborative team that serves these patients. And so, there is probably, I can say with a pretty high level of confidence, some sort of collaborative work happening somewhere in Georgia. Whether it's charm, I can't say for certain. I'm happy to do some Googling to see if I can find it. And if you know of one, please let me know because I'm always looking to understand who's doing this work elsewhere.
Awesome, thank you. It looks like folks are asking about Louisiana and Massachusetts. I did add a link to the publication that does talk about a couple of other models, one in Arizona. Um, and then I will add Dr. Martin's links in the chat as well. And another question that came in regarding charm is when you engage with your champions, how do you build out that space? Do you find committee meetings work or some other format?
I think if this is a brand new idea to your area, oftentimes finding your champions happens intentionally but casually. So when Charm started, it was literally conversations in the hallway of the medical center between a couple of doctors and a social worker saying like we have to do this differently, there has to be a better way. And I think that's often how this happens because if you go in full steam ahead, people are often like, this is too much. This is impossible. How could we do this? It feels too overwhelming. So, my recommendation is when you're finding your champions, approach them with intention, but with sort of humility and maybe a little bit of casualness. Invite them to coffee to talk about their perspective on this, how they think collaboration might work. And then I do think you can start to look at more formalized committee meetings as you're getting further into your process, as you're bringing more people in, as you're starting to talk about what this could look like. If you're thinking about your collaborative framework, like an MOA, I think that those sort of meetings can really help. And I will always recommend to have someone who can hold the administrative work. Oftentimes, we're really busy, we're serving our patients, we're serving our clients, and we miss the important work of the admin. So who's sending out the meeting link? Who's, reserving the conference room? Who's developing the agenda and emailing it out? Try to designate someone to hold that work because it will allow you to not get bogged down in those details and instead be focused on what you're actually there to do, which is to create this team for your patients.
Awesome. Thank you so much. I don't see any further charm questions. Apologies if I missed any in the chat. I do see a couple of additional questions coming in about 7OH. So thinking about that substance that's derived from kratom, mitragynine. Uh, the question, let's see, one is, have you heard about 7OH now? Similar to kratom, but more potent. And then the other question is, are you using to treat 7OH use?
People are asking a lot of questions about things we don't have any data for. All I can really say right now is again, we were offering patients buprenorphine inductions if they have 7-OH use, in addition to all the other things that we're doing, right, to try to promote healthy outcomes for these patients.
Excellent. Well, I think that wraps up the Q&A. I thank you both for sharing your expertise today. It's been very informative and absolutely wonderful. And I will go ahead and close us out. So, attendees, thank you so much for joining us today. We really appreciate you taking the time to participate, and we hope that you found this session informative and invaluable to your work. I'd like to extend our sincere thanks to Dr. Caitlin Martin and Megan Masterson for sharing their expertise, insights, and time with us today. And I want to share a few resources and reminders for everyone. So first, please everyone go ahead and use your phone. And now I'm encouraging you to multitask here, but if you could use your phone and snap that QR code for the evaluation survey, I'll also be adding it into the chat momentarily. It just takes less than a minute to complete. Your feedback is anonymous and it helps us to improve future webinars and resources. We also encourage you to explore the Postpartum OUD Care Transitions publication. I've added that link in the chat a few times, and it is available through this additional QR code here. And then for any additional evidence-based publications and resources, please visit the SAMHSA library at library.samhsa.gov. If questions arise after today's session, please feel free to contact us through the EBPRC mailbox. Finally, a recording of today's webinar will be posted on SAMHSA's YouTube channel within approximately 2 weeks. Thank you for being with us today. We appreciate everything you do, and we wish you a wonderful rest of your day. And if you want to stick around for just a couple more seconds, I'm going to add a few more links into the chat if you missed them. Let me just add those now. And lastly, I will add the link to the evaluation for today's session. Thank you, everyone.